Hi, good afternoon. Thanks for being here for our monthly mental health and addiction rounds. My pleasure to introduce today Dr. Chithra Pream Raju, who is a clinical assistant professor in the mood disorders program in the UBC Department of Psychiatry, as well as a staff psychiatrist at the Richmond Hospital and Mood Disorders Center here at the UBC Hospital. And today she will present on magnetic resonance spectroscopy in bipolar disorder and if that predicts recurrences. So please welcome Dr. Raju. Thank you for being here.
Thank you for introducing me, Lily, and it's a great pleasure joining you all today at the Matrix and Cluster to present my research on magnetic resonance spectroscopy findings in bipolar disorder. Do they predict recurrences? I start with acknowledging that we have gathered on the unceded territory, traditional territories of Musqueam, Squamish, and Salish nations. There's no conflict of interest in the presentation today. Hi. So the outline of my presentation today would be, I'll give an introduction to bipolar disorder and talk a little bit about the neuroimaging biomarkers of bipolar disorder and why magnetic resonance spectroscopy, followed by proton magnetic spectroscopic findings in bipolar disorder, followed by the proposed study that we have been doing and the preliminary results of the study with the implications. So bipolar disorder is a chronic recurring mental health disorder with a lifetime prevalence of 2.4%. And it has recurring episodes of mania, depression, and hypomania. So mania being they're very happy or they're very irritable, and then it's associated with psychotic symptoms, and depression, they're very sad, and then there are other associated depressive symptoms and may not be associated with psychotic symptoms. There are also hypomanic phases. However, bipolar 1 is predominantly known to have manic phases. So today I'll be talking more about bipolar 1 disorder rather than bipolar 2 disorder. So especially first episode mania. So first episode mania, it marks the onset of bipolarity. And so if you see within the first year of remission of first episode mania, it is known, it's seen that 58% of them recur and around 74% of them recur within 4 years of the first episode mania onset. And it's also associated with increased suicidality, disability, and following on to, which leads to poor functioning. So that's the need for knowing more about the recurrences in bipolar disorder, because we are not able to prevent the recurrences and predict the recurrences in any way. So if you see what happens over time is that neuroprogression occurs in bipolar disorder, especially with a lot of clinical changes. So whenever there is recurrent mood episodes, if you see here, there are a lot of clinical changes over time, and the episodes over time become more severe and intense in nature and more longer in nature. And it'll lead on to cognitive impairment, functional impairment. And there are a lot of biological changes that have been ongoing, especially in terms of inflammation, oxidative stress, mitochondrial dysfunction. And there are studies to prove all these mechanisms in bipolar disorder, especially over time. So it's important to know the recurrences or the neurobiological underpinnings of these recurrences in bipolar disorder. And with all these changes occurring, what happens over time is that there is increased vulnerability to stress. So even there is a minor stress in their life, they're not able to handle those. And that again further leads on to recurrences in mood episodes. So there are various clinical factors that have been found to be predicting the recurrences, especially age, younger age, and then number of previous mood episodes. If there are more number of episodes, then there are more recurrences, and subsyndromal symptoms or residual symptoms, what we call it, like even if there are some symptoms of sadness or say other mood symptoms like say mania or hypomania, which are not at the syndromal level of being diagnosed by DSM-5, but they're still making them dysfunctional over time. These are known to predict further recurrences, and also comorbid anxiety and substance use disorders have known to predict recurrences in bipolar disorder. However, it's not very personalized and it's very difficult to accurately pinpoint why one has recurrence in their lifetime. So we also know that BD is a state of chronic neuroinflammation with a multi-system involvement. And there are changes that happen at the cellular and molecular level with changes in the mitochondrial metabolism and neurodegeneration, with the implications in few areas like, say, hippocampus, prefrontal cortex, basal ganglia, anterior cingulate cortex. These are the most studied areas in bipolar disorder, with the role in mostly in memory and emotional processing. So over a period of time so there have been findings with the structural and the functional MRI in these areas, which is implicated to have cognitive impairments over time in bipolar disorder. So they have also been used as diagnostic tools or explored as diagnostic tools, whereas clinical observation is usually the main thing to diagnose, but still they have been studied as diagnostic tools and predictors of further episodes or say a response to treatment. However, it's very difficult to pinpoint on one factor, as we all know about bipolar disorder. So the neuroimaging biomarkers in bipolar disorder include structural changes. We have structural MRI findings. We have various functional MRI findings, decreased activation in the gray matter, in the limbic circuits, and we have diffusion tensor imaging. And we also have newer studies coming up with microstructural changes, especially with those on neurite densities and with the diffusion weighted imaging. And we also have magnetic resonance spectroscopic imaging, which is mostly have been studied as a diagnostic tool. However, we don't have studies that talk about prediction of recurrences, unlike major depressive disorder. So where major depressive disorder, it has been studied as a predictor of recurrences, but there are very few studies. Nowadays, we are also moving towards precision neuroimaging techniques like machine learning techniques to see the accuracy of prediction. And there are a few studies which talk about precision imaging recently. So why we chose magnetic resonance spectroscopy? Because it is non-invasive like most MRI. And the most important thing about these magnetic resonance spectroscopic studies are that they're imaging, but we get the levels of the concentrations of metabolites in the brain. So that's something interesting, and it is non-invasive in nature. So it also allows us to do repeat measurements, and then we can follow patients longitudinally and evaluate response to treatment, and also allows measurement in healthy controls. And it can be regionally defined, and it offers assessment of the brain functions like neuronal integrity, neurotransmission, mitochondrial function, and then protein breakdown, and also membrane synthesis or breakdown, and antioxidant reserve. So this is something interesting with magnetic resonance spectroscopy, because we have always found structural changes as decreased volume, increased volume, but underpinnings of what is happening within those structural changes is something which is exciting. And it can be captured by imaging, which is much more exciting with magnetic resonance spectroscopy. We don't have to do a blood test to know these chemicals, what's happening with them, and so on. So what do they detect? So what happens with magnetic resonance spectroscopy is it's the same principle as the MRI. And what happens is, so there are radio frequency pulses that are exerted and that are exposed to certain localized areas, and they give out a few spectra, which can be converted to absolute concentration or ratio concentration of metabolites. So in this, if you see, NA has multiple peaks. So there is one here, and then this is also NA, a metabolite of NA, and then this is NA. So there are multiple peaks, and these are markers of neuronal integrity. And there is also creatinine and phosphocreatine, so which is measured as total creatine. There are two peaks here. If you see, this is the frequency. So it's around 2.8 to 2.8 to 3 here, and then we have total creatine here too, and also we have membrane turnover, that is the choline, and lipids, which can be measured. So it's around 3.1 to 3.2 here, and and we also have myoinositol, which measures the glial cell density. We also have other chemicals being involved. Chemicals detected with MRS, that is the that are involved in neurotransmission, GABA, glutamate, and glutamine. And also we can measure glutathione, that is the antioxidant reserve, with MRS. So what happens with capturing, what are the steps in MRS? So initially, so there is a lot of water in the brain, so that has to be suppressed. So those will be suppressed, and then there are water suppression signals, and then we do localization based on the oxal size and everything. And then there is a signal that we receive, and we process those signals, and then we do fitting with the basis set, metabolite basis set, and then we quantitate the metabolites. So these are the steps involved in magnetic resonance spectroscopy analysis, and we end up getting absolute concentration of the metabolites that I spoke about. Yeah, these are some of the steps involved in data analysis. Like I said, some of the processing is done while the image is captured, whereas some of the processing is happening after the image is captured, like phase correction, frequency correction, and all that. So then we do a spectral fitting, and we also do tissue correction for the gray matter, CSF, and the white matter present. And then we quantify the metabolites. And the last step is very important, where we assess for the spectral quality using certain measures. Okay, so this is so far about a brief introduction with magnetic resonance spectroscopy and bipolar disorder. Now I move on to consolidate the findings that are so far in the literature regarding mania, depression, and euthymia, and various metabolites. And I'm going to focus on NA, which is very easily available to everyone. Like, say, it's easily measured using MRS. So I'm going to focus on two metabolites, that is NA and glutamine, because these have been implicated in bipolar disorder. Especially NA was found to be decreased, so which in turn indicates that there has been neuronal changes with respect to neuronal loss in the brain in bipolar disorder. And the second one is glutamine. So there is increase in glutamine, especially in bipolar disorder with manic states. These are the findings that have been found. I mean, that have been in the literature so far. I mean, in general, but still there are other findings which we could see here in the coming slides, which kind of is inconsistent with what I have been telling, like decrease in NA and increase in glutamine. This is just overall, like, from the majority of studies that we have found. So with mania, if you see, as I told, today also I'll be focusing on just two areas, hippocampus and dorsolateral prefrontal cortex, because these are the most studied and most implicated regions in bipolar disorder. So what we see here with these three studies is that one is about the field strength. These are all 1.5 Tesla. And we have a very small sample size here. I mean, at least Frey has 32 on both sides. And then the region of interest here is the dorsolateral prefrontal cortex. And if you see metabolite study, with respect to NA, there are not much of differences between patients versus controls. Whereas with respect to glutamate, as I mentioned earlier, it was elevated in the dorsolateral prefrontal cortex, whereas the other studies showed not much of a difference. Whereas in depressive episodes, this is in hippocampus mostly, we found again lower Na to choline ratio, and there is Na glutamate. There is not much differences in the other study, and there is decrease Na again. And yeah, if you see the last one, it was in bipolar 2 disorder, where it is mostly increased in all the mood states. However, if you see the field strength, again, it is 1.5 Tesla, and only one study was 3 Tesla, and that did not show much of differences at the baseline, at least. But there was increase in Na and glutamate after lithium monotherapy for 6 weeks, which is the treatment, well-known treatment for bipolar disorder as a mood stabilizer. With respect to euthymia, so this is, what do you mean by euthymia is they don't have any episodes. They are in a normal state. They are in remission from all the episodes. With respect to euthymia, the findings again vary. So I have I have actually summarized the evidences with hippocampus and dorsolateral prefrontal cortex here. So with hippocampus, again, it was lower. And patients also had cognitive dysfunction, and some of the studies were mostly response to treatments as well. Yeah, so treatment with galantamine showed increase in Na. So similarly, they have found treatment with lithium has shown increase in Na after like 2 measurements at the baseline. As after 6 to 8 weeks of lithium therapy, they found there has been increase in Na. And valproate also has known to show such findings, which I'll talk about later. However, overall, if you see Na is lower, be it either ratio concentration or absolute concentration. Na seem to be lower in these studies in hippocampus and dorsolateral prefrontal cortex. But if you see the echo time and the repetition time, that is the TE and TR, which are the measurements that are used to capture the imaging in the earlier. So in the earlier part of the imaging time, like during the imaging time. So this is very important because we need to have shorter TE and at least 2.5 seconds of TR to reduce the signal to noise ratio and get a better signal. And here, if you see, the studies have variable TE and TR and mostly longer. And the field strength is also 1.5 Tesla mostly, and very rarely, like just 3 or 4 studies, 5 studies have 3 Tesla here. And if you see, the studies were mostly done earlier in 2003, 2008, 2015. Yeah, these are the findings with euthymia. As I mentioned earlier, effect of treatment has shown to change or the metabolites, especially increase in Na after lithium therapy is known and well known. And lithium is also one of the, as a neuroprotective agent. And valproate has also shown to increase Na, but it's not as much as neuroprotective as lithium. And lamotrigine was also, it's also a mood stabilizer. All these 3 are mood stabilizers, which are used to stabilize the mood to much more normal state, which is what we call it euthymia. So we don't want the fluctuations in the mood, and that's why these mood stabilizers are given. And when they found they had a baseline value, they had measured it at the baseline and also after 8 to 6 weeks of therapy, and then they have found some changes. So there have been a few systematic review and meta-analysis, which have also pretty much detected the same. However, there is one study which was done in 2012, which reported that there was increase in Na that approached significance in dorsolateral prefrontal cortex. And there was also inconsistency with respect to the findings in other studies. They weren't able to actually do a meta-analysis with some of the studies, and because there was a lot of heterogeneity with these studies. And they have actually, even when they have done meta-analysis, it was noted that not just hippocampus and dorsolateral prefrontal cortex. They have combined all the areas and they have done a meta-analysis, which is also kind of very difficult for us to interpret from that meta-analysis and systematic review with respect to what are the changes actually that has been happening in these patients. How are we going to like there are so many studies, there are so many changes in metabolites, but how do we actually come to a conclusive state of what is happening in the brain chemically? So yeah, that led us to think about different methodology and a different type of analysis, and which overcomes the shortcomings of the findings that has been so far available in the literature. So yeah, what are those inconsistencies? Like I mentioned, some of them, most of them were 1.5 Tesla, so which will cause more of signal to noise ratio, and then the signal is not strong. Like it's very difficult to interpret from these. And some of them are single voxel versus MRSA, magnetic resonance spectroscopic imaging, which is the voxel size is different, the placement is different, the white matter, gray matter contribution changes. So it's very important to localize these brain regions so that there is no overlap with the ventricles nearby or gray matter, like how much they contribute and all that, because that's one of the things that we are also facing with our analysis, which I'll be talking about later. And also the TE and TR parameters varying across the studies. It's not consistent at all. And if you see earlier, it was thought that creatinine is something that will not reduce in the brain at all. And if that reduces, it was thought that, yeah, brain is dead or something of that sort. So everyone started thinking that as a reference, and they were using that as a reference. And that was actually not true. Over time, it was found that it's not the right way of quantifying the metabolites. So they started using water as a reference. And that's another important drawback with those studies that were done earlier, because they were either ratio concentration to creatine or choline. And then if the denominator changes, then it's very difficult to actually predict the numerator there. And so that's again inconsistent. And most of the studies were underpowered. And especially like I showed with different phases of bipolar disorder. So some of them in mania, some of them in depression, some of them in euthymic mood state. So it's very difficult to separate them with these three mood states and different stages of illness. Like earlier in the stage of illness, whether they had like a first episode mania and then they had these studies, or they had like a later stage of illness and then like different people, we are not sure about that. And these were not reported in the studies, and treatment effect was also not specified in these studies. So, and it was very surprising to see how the meta-analysis was combined when different regions were combined. Like it was not the meta-analysis was not specific to hippocampus or was not specific to dorsolateral prefrontal cortex. So there were different region studies. So they just combined that and they gave a finding. So we're not sure how consistent that is. And also, many of them have studied only as diagnostic tools to see how these metabolite changes over time in bipolar disorder. I mean, not even over time, sorry. It's just at that point, cross-sectionally, how the metabolites changed in these states. And nobody has actually correlated it with the rates of recurrences. So that was something novel that we wanted to do. So systematic treatment optimization program for the first episode mania study has been running for now, I think, close to 10 years, which is under Dr. Yadam. We started the study in 2004 to 2005, where based on the DSM-4 criteria, first episode mania patients were recruited by either with or without psychotic symptoms or without comorbidity, so that they can be a representative of the population, like they can be representing the real world setting. So within the 3 months of first episode mania was captured. Like say, so as I told earlier, first episode mania marks the onset of bipolarity. And that is when we say, so like that's the characteristic feature to say that bipolar disorder has been diagnosed with this patient. So this is more to, the reason why I'm reiterating is that this is in the earlier stage of illness that these patients were recruited. And they were recruited from 2009 to 2015. And we plan to follow them up. It's a naturalistic follow-up study for 10 years. And we have completed successfully 10 years for most of our patients. And the exclusion criteria for the study was standard criteria for exclusion for any MRA, or if they had a previous manic episode, because we targeted early stage of bipolar disorder. And we also had age and sex matched healthy controls without any previous history of psychiatric disorder or family history of psychiatric disorder in a first or second degree relatives. So that, and the other catchy thing here is that they were also followed up for 10 years. So the follow-up was also for every 6 months, I think until 10 years. And after 10 years, we started reducing it to 1 year. And around COVID, I think we had to kind of reduce the frequency of follow-up. So it was slightly impacted during that time. Otherwise, we have so many patients who have completed 10 years follow-up.
The exclusion criteria, if they had a previous manic episode, they weren't allowed to be in the study.
Yes.
But isn't it a combination of depression and mania that defines bipolar disorder?
That's not really. Once we have first episode mania, we can actually tell that they have bipolar disorder. For diagnosis, we don't really need a depressive episode in the past. So only mania is required to diagnose them as bipolar disorder. And they can have previous depressive episodes. They were included, but if they had a previous manic episode, they were excluded. So
because you didn't want to confuse it with pure mania, is that, if there is such a thing?
I think I didn't get the question. So
sorry, I'm still having trouble understanding. So it's the sequence of mania and depression, the co-occurrence, obviously.
Yes.
They have to occur in a certain order.
Not like that.
Okay.
Yes. So bipolar disorder, that's another thing. So if we have just one manic episode, we can call them bipolar disorder.
But then they have to have depression as well.
No, they don't have to.
You can be bipolar and only have a unipolar mania.
Yes.
Well, that's an odd definition. I'm not doubting it. I'm just saying.
Yeah. So just having
logic makes no sense.
So that's why we have yeah, it's a kind of probably I should say a misnomer, but even if you have one episode mania, we can say them as bipolar disorder. So that's where marks the onset of bipolarity. So just depression, we call it major depressive disorder.
Okay.
Yeah. But then if you have one episode of mania, irrespective of not having a depressive episodes, we call them bipolar disorder.
Yeah. No wonder the data you just showed us so unimpressive. Not your work, but the whole literature.
Yeah.
I guess in this field, your ability to see things is only as good as your ability to detect the true underlying psychiatric state.
Yeah. Okay. Okay. So we also had MRS data acquired in these patients, both T2 and T1 weighted anatomical images, and we use a press sequence to localize the hippocampus and the dorsolateral prefrontal cortex, and we followed we kept a fixed oxal size for hippocampus and dorsolateral prefrontal cortex. However, we had the initial protocol with 35 milliseconds of echo time and 2000 milliseconds of repetition time, just in hippocampus. Whereas in the second protocol, when we did it over, I think around 2015, we changed it over to 24 and 3000, because over time we also learned that it's important to reduce echo time and increase the TR time to improve the signal to noise ratio and have a better signal. So, and we also included dorsolateral prefrontal cortex at that time. And so there were chemical shift selective pulses to suppress the water signal, and there were water unsuppressed signals too. So around 128 water suppressed and 116 non-water suppressed transients were captured, and they were averaged and processed while they got the images, the spectra. So the sample size that we have so far is, at baseline, we have 78 people in the FEM1 protocol, and with the age range around 22 plus or minus 4 to 5 years. And then we had equal proportion of male versus female too. And then they were followed up for at least 5 years, like around 26 were followed up for at least 5 years, and 21 were followed up for at least 10 years. Whereas if you see the controls, we had 35 age and sex matched controls with the same age range and equally distributed male and females. And but the issue is we had only 6 or 7 of them followed up over time. And we also had 17 patients in the FEM2 protocol. We don't have follow-up in this set, but we just have the baseline with them. And some of them have year 1 follow-up. And we have 30 controls in this FEM2 protocol. So the images here, I have consolidated only year 5 and year 10. The images were acquired at year 1, 3, 5, 7, and 10. So we have much more than what is here, but we chose to do, I chose to present these ones here today. What has been published so far from our study is that we had around 58 patients versus 27 controls with the FEM1 protocol, where the metabolites like NA, glutamate, choline, myoinositol, and creatinine were studied at baseline. There were no differences between patients and controls. This is in hippocampus. Whereas in 2015, we studied glutamate, and it with BMI, the relationship with BMI. So it was noted that higher the BMI predicted higher glutamate. So that was one of those studies where we looked at the BMI. And there was also another study with BMI where higher BMI was associated with lower NAA. And we also presented another study, the same analysis with 1 year follow-up, where there was not much group or time-related effects between patients and controls, and no differences with or without recurrence of another episode. And this was in the early stage of illness. So the conclusion that was made earlier was, in the early stages of illness, there are not much changes in the underpinnings, the neurobiological underpinnings. So it would be important to treat them at that time in the earlier stage of illnesses. So that is the focus of understanding the neurobiological underpinnings, is that treat them in the earlier phase of illnesses so that they don't have neuroprogression. We can arrest the neuroprogression, and so that they don't have cognitive deficits over time. And the cognitive deficits can in turn also act as a risk factor for dementia, because it has been shown that there's out of around, I think more than 40 to 50% of them have risk factors like to develop dementia later in the course of illness.
How were they treated? Obviously, this lithium antidepressants.
It was variable. There is no specific treatment protocol for these patients. So we wanted to, in a sense, it was variable, as in some of them were chosen on lithium, some of them were put on valproate, but it was based on the clinician's need, so that is reflective of the real world setting, rather than having them to randomize to just lithium or something like that. So it was
And would you expect different MRI spectra depending on which drugs the individual was given as part of their treatment?
That is something which we have been thinking about to take into consideration while we are analyzing, because for so far the studies have shown that there has been changes with the treatment,
Regardless of whatever they were.
Yeah, exactly. So if there were low NAA at the baseline, it was shown to be increased NAA over time with lithium after 6 or 8 weeks of therapy. And then there were like also with valproate, it was found that way. But there are not many studies with antipsychotics because we generally tend to give mood stabilizers plus antipsychotics, especially in the beginning of the, like if it's severe episode. So combination therapy is also given for most of the patients. So. Okay, so what did we plan to study? So do these metabolite levels in hippocampus and dorsolateral prefrontal cortex in patients with first episode mania predict recurrences of mood episodes with all the 10 years findings. The outcomes were the relationship between absolute concentration of NAA or glutamate and the time to recurrence of any mood episode. And at the baseline, how it was, and also changes in concentration at different time points like 1, 3, 5, 7, and 10 years, which we are still working on. For now, we have looked at the baseline. Secondary outcomes is to also see how it is differing between the patients versus controls at baseline and over time. What is new with our study? What is something that is catchy or something interesting in our study is that we took a homogeneous disease phase with patients scanned within the first 3 months of their first episode mania. That is within their first, in the early stage of illness, as soon as they were diagnosed as bipolar disorder. So also they had 3T MRI, and then the T was a little lower, which also has reliable detection of glutamate, which can be separated from glutamin. So most of the studies that have reported glutamate earlier have combined glutamate and glutamin together and presented. So here we can actually separate this out with the 3T, and also we use water as a reference signal here, which is a more reliable method of quantification of these metabolites. And we had 4 regions studied, that is right and left dorsolateral prefrontal cortex and hippocampus. And also, this is the first study to have the longitudinal assessment so far. There have been studies in the past which have done 8 weeks of longitudinal assessment. That is like before and after lithium, before and after valproate. But this is like pretty much a reflection of a real world setting where the treatments were variable, but then they still continued on to follow up with us with the details of the treatment as well. And yeah, we have all the assessments over time. We also have controls. That's another interesting fact with our study. So what did we do with the analysis? So usually magnetic resonance spectroscopic analysis is done with a LC model. So to obtain the spectra. So that is what the usual analysis that has been used. But however, we have decided to use FSL MRS for the analysis, which is a new upcoming software with much more much more reliability. Especially they don't have a metabolite basis set. So as I showed earlier in my in the steps where we do the MRS analysis, so where we do the fitting, so we do the processing and then we do the fitting. LC model does not use a metabolite basis set, whereas here we have a simulated basis set. And we can use that for fitting. So the fitting quality is much better. And it also gives the quantitation of the metabolites, whereas LC model doesn't give the quantitation. We will have to do it manually. So that's about the importance of FSL MRS. So that's a novel analytic technique as well. One thing is about the study in itself, how it was designed with the longitudinal follow-ups. The other is also about the way it's analyzed. So we are trying to overcome the shortcomings that are there in the literature so far with a homogeneous disease phase. So we can actually see the early stage to later stage as a metabolic, like the metabolic signature of these patients can be seen from the beginning till 10 years or 15 years, sorry, 10 years, especially because we have the imaging till 10 years. And also that we have two different regions from the same patients in both right and the left. And we also have healthy controls. That's another thing with follow-up. And then we have a much more reliable method of analysis right now, so that we can do the fitting much better. And then we also can quantify them with an absolute with absolute metabolic concentrations rather than ratio concentrations that was used earlier. What's exciting about the preliminary results? So before I come to the results, like there were quite a few challenges that we faced with the steps in this data, because it was not easy to get that preliminary results itself. Because it was an old data and we were feeding it into a new analysis software, we started facing technological difficulties in terms of processing them and getting an accurate fit at them. So most of them had, and as I was talking about localization earlier, so because it was not localized accurately, sometimes it was kind of overlapping with ventricles. So the concentration of CSF was higher. So we had to exclude some of them based on the percentage of the CSF. So while we do the tissue extraction, like say we also, while we do the quantification, we also take into consideration the gray matter, white matter, and the CSF percentage. So when we take care of those, whoever had higher CSF percentage had to be excluded. So we ended up excluding so many of them in the initial phase. And we noted that over time, there were so many patients that we had to exclude, and there were so many phase corrections, frequency corrections, all those had to be changed. And over 10 years, there were change in the protocols. There were change in capturing the images. So we had difficulties to go back to their timeline as to what was changed. And the angulation of hippocampus was kind of changed. So we had to make all the things correct. So there were a lot of technical challenges with this data. And then that's why I had to present only the few analysis that I could do, like with few patients, because we are still analyzing it, correcting all those technical challenges. And now we have reached to much more, like around more than 50 are now good enough for analyzing. So this is preliminary results. So we are so excited to see how it's going to look over time. That is something which is very exciting. So in this preliminary result, what I found was, so here we had around 17 patients and 17 controls with the age range of around pretty much the same that we had earlier, like around 20 plus or minus 2. And male and female equally distributed. And we had, they had psychosis, around 14 of them had psychosis, and around 4 of them had substance use as comorbidity, and anxiety disorder as comorbidity. Around 5 people had them. However, if you see here, NAA is significantly higher in patients versus controls. While I was talking about it earlier, if you noted what I was talking, we were talking about lower NAA because of the neuronal loss in the early stages. Neuronal loss, and with treatment, it got improved. That's what we studied. That is what, in general, overall consolidating the literature that has been present so far, we arrived at that conclusion earlier. However, in our sample, it is noted that NAA is significantly higher, and glutamate was kind of lower in patients. So we were wondering, because these patients were actually imaged after the treatment of first episode mania, they were kind of close to remission during the time. They were in remission, because it becomes very difficult to do an MRI scan for a manic patient. So that's another challenging thing, that we don't have much of studies in mania, but we have studies in depression and euthymia. So that is why they were at least maintaining 2 weeks of euthymia close to the MRI, close to the MRI scanning. And what we think is probably it could be because of the medication effects, that the NAA is higher and the glutamate is lower. So that could be one of the reasons, but then we need to see this over time with medication as a confounding factor. Like we need to control for the medication effects and have it divided with, like say lithium, was there any difference? Or with valproate treatment, was there any difference? We need to do like divide them into groups, subgroups, and try to see how it works, because it's difficult to come to conclusion at this point. But this is what we are thinking it could be one of the reasons. And with the Cox regression analysis, for like with respect to the baseline NAA versus glutamate, they did not predict the time to first recurrence. That's what we found. We haven't gotten into the year 1 and year 3 or year 5 and 7 and 10 results so far, because year 1 itself, I mean, the baseline itself, we were stuck with all these technical challenges, and yeah, it has been difficult to move on to the other steps of fitting. So hopefully, I'm so excited to see how it's going to be over time. And I'm also working on the clinical outcomes of these patients, like course of these patients in 10 years. So I'm working on that as well. So I would want to correlate both of it to see how it differs over time, clinically and neurobiologically, which would be interesting to see from earlier stage to later stage. So that's our further proposed plan of like continue. I mean, and I'm also planning to continue to do both of it over time. So yeah, what we concluded, there are changes in NA or glutamate in patients with BD. We are not able to really tell why that increase or decrease at this point, but there is for sure something that's happening there. But early in the course of illness, they don't predict recurrences, which is much more reassuring. That early in the phases, there is some chances for us to think about earlier, treatment, and it's important to work on or treat them very well in the earlier stages so that we can prevent recurrences in the future. So the recurrence rates that I told earlier was also from this study. So from the patients in this study. So around 58% of them had recurrences in 1 year, and around 74% of them have had recurrences within 4 years of the first episode mania. So that is the conclusion. Yeah. Implications. Yeah. I mean, at this point in time, it's very difficult to come to a conclusive evidence from whatever the literature has been there so far, like with respect to the changes or with respect to the neurobiological hypothesis that we have been having so far. Is something which needs to be studied further. I can't come to a conclusion at this point. So I believe that our study will make that foundation to take it forward, to make much more change. I mean, it can add on to the evidence further to make it as a first step. And then maybe I myself can think about having my own study of finding these changes with the prospective group again, yeah, later in the point. I mean, if with whatever shortcomings that we have right now with respect to the localization and then the CSF percentage being more, and to overcome these shortcomings, if possible, I can work on those later in my career. And we can also work on the treatments that are targeting early in the course of treatment with this metabolic signature. If they give, because we also have other metabolites. I have just focused on NA and glutamate because that has been mostly studied. We also have myoinositol, we have creatine, we have glutathione and others. And with the newer modality to analyze them with much more better quality, I hope we'll be able to make much more changes in this field of neuroimaging biomarker with MRS and bipolar disorder. Thank you. Yeah. I thank my supervisor, Dr. Yadav, for giving me this opportunity to join the translational research team. And yeah, so this has been wonderful to share my findings with a different group of audience, and it's also a great experience for me to yeah, make it much more understandable for everyone. So yeah, thank you so much. I should. Thank you.
Bob, who's sitting there patiently.
Dr. Raju, can we ask questions or?
Yeah, for sure. Just
Thank you for that very interesting talk. I realize this is like an enormously challenging field, and I think it's great that you're so aware of some of the technical nuances. I think you're absolutely right that you're somehow gonna have to factor out the effects or control for the effects of valproate because, as you know, first of all, valproate commonly, in fact, ubiquitously causes elevation in glutamate, in blood glutamate, and it causes and the degree is variable between individuals, and most patients don't develop clinically significant hyperammonemia, but it's common to see, hyperammonemia in the range of like 35 to 50, with the upper limit of normal being 35. It's very, very rare to find a patient who doesn't have an elevated ammonia. And then valproate also causes a shift towards glutamine. So that on MRS, that's been shown in epilepsy patients. And then myoinositol, there's evidence too that valproate influences myoinositol concentrations. So I think it would be interesting if you have enough patients to compare like the lithium and the valproate group. But the other thing that would be interesting is to look at outliers, because there are some unusual complications of valproate, including one which causes a slowly progressive, insidiously onsetting either Parkinsonism, cognitive impairment, or both. And it's associated with rather dramatic volume changes, so that these patients are actually described as having pseudoatrophy. And the atrophy, quote unquote, is out of proportion to the degree of cognitive impairment. And it's called pseudoatrophy because it's reversible if you stop the drug soon enough. And it's probably a mitochondrial effect. There are two patients who independently described in the literature with the same mitochondrial mutation and this syndrome. So I think, anyway, it would be interesting to look for outliers, I think, in your patients. And I'm wondering if it would be at all helpful would it be helpful to do like a blood ammonia concentration at the time of the scan, just to correlate that and see if there was any effect on the brain glutamate and glutamine peaks.
That's interesting. Thank you so much for sharing that. Yeah, I've been thinking how to control for these medications, because it is also in our study, it has been very difficult to keep a track of these medications. We've been cleaning the data for quite some time now, because it took a lot of time to even do the clinical outcomes. It's difficult to keep a track of these medications, but then we do have around at least half of them on lithium. So for sure, the other ones are on valproate. So we will be able to do a subgroup analysis, is my understanding, but I'm not sure that is with the clinical, just with the clinical patient, I mean, clinical outcomes. But however, I'm not sure if those patients would have like respective imagings and fitting as well. So I'm not sure about that. I need to look into my data over time to get that finding as well. So that's what I was thinking about, maybe doing something else later, planning something else later with all the shortcomings kept in mind, especially medication effects. That would be the second level of it going forward. Yeah.
Thanks.
Sorry, I was just seeing if there's anything there. You mean the recurrences? Okay. That's a really great thought, because it has been difficult to, I think to be honest, it is difficult to have that timeline between that, but for sure we can take into consideration, because we have the timeline of the episodes. So we do have, and then we also have it in year one, the dates of the episodes, and the year 2, year 3, year 4, and year 5. And we have the dates of the MRI. So we can look into the dates, but I haven't really thought about it for the coming years. One is medication, which I thought about, but we haven't really thought about the recurrences, how we are going to do. Like the other thing, what I've thought about is to see the number of recurrences over year, but I haven't thought about the closeness to the MRI imaging, but that'll be a good idea to have in mind to look at it later when I'm looking into the imaging data. Thank you so much.
Another point of clarification. The 17 people that you were describing at the end of your presentation, was I right in seeing that 14 of that 17 had a psychotic episode?
That's right. Yeah. Yes. So
how could you differentiate between the effects of the psychosis and the bipolar effects that you're trying to understand?
actually, mania can occur with the psychotic symptoms and without psychotic symptoms as well. So what we always think, if they have the psychosis episodes and the manic episodes, we usually consider them as predominantly from the mood effects. We don't usually separate them out as psychosis and mania when they have that. But given if there is some population, there are people who have like no psychosis, then we can plan to do like
have 3 of those.
In this, at least. That is a whole problem with mania. It's usually very severe, and especially what the sample that we have are mostly from tertiary hospitals, referred in and around Vancouver and from Vancouver Island, Victoria Hospital. So we are also a representative of more severe illness. Like mania is in itself severe, but as such, those are hospitalized, and those with the psychotic symptoms. And I think we'll also be talking more about mania with psychosis rather than representing just mania there. But it's also that around 80% of them are usually associated with psychosis. So it's difficult to separate. Yeah.
Arguments about diagnosis.
Yes. So it's just the way we have made the way to diagnose the disorders now with DSM-5. So differentiating it from, so obviously the mood component is significant, and that's why we have had mania with psychotic symptoms. And even in that psychotic symptoms, we have something called mood congruent and mood incongruent psychotic symptoms. And what would be more beneficial there is if we have to differentiate it from the psychosis part, then I think if the mood congruent psychotic symptoms people are more in number, then they would be kind of going into like say schizo affective over times. Usually the course of illness is like, so when they have mania with congruent psychotic symptoms, it's usually considered as a mood disorder. But when they have like incongruent psychotic symptoms, which are very predominant, then over time, the diagnosis also sometimes changes to schizoaffective disorder, which is like a overlap of schizophrenia and affective disorder, like especially the first rank symptoms that Schneider reported, like say those 13 symptoms with Schneider. And if those symptoms are present, then we end up having this discussion between whether they're schizophrenia itself or whether they're mania itself. So that is going to be like another debate of how, like with the diagnosis itself, like you said. So
being a psychiatrist, I'm very much in favor of going to these domain criteria. And don't get confused. In precision.
it's just at the end of the day, it has become like to see the history, how it evolved from manic depressive psychosis to, or say schizophrenia being a neurodegenerative disorder to
I know the history well.
yeah, no, what I'm thinking is like, I think after some time we will be going to what you are saying as
Well, the NIH tried to encourage people to think differently about, get away from diagnostic statistical manuals, start to look at
the
subsets
neurobiology.
of psychiatric, cognitive, affective, all this stuff. But
That's right.
in terms of the primary symptoms, they have a whole very well reasoned approach to doing this. But it doesn't seem caught on. I think we need a new generational change.
Exactly.
So you can be the interpreter between the two approaches.
At the end of the day, what we treat is basically the symptoms, right? Like say depressive symptoms with
Yeah.
SSRIs, even if they have schizophrenia. Pharmacologically, I think we end up treating as psychotic symptoms, we have the D2 blockers. And then if they have depressive symptoms, then we go to the neurobiological thing. So probably over time, what I was thinking is with history, like how it has evolved with the DSM, it would evolve to neurobiologically differentiating the symptoms and then treating them.
Send you a reference to the main criteria approach.
The RDoc,
Oh, no.
yeah.
Yeah.